Good afternoon. My name is Alexis Kush.
My name is Emily Wilson.
Today we are presenting a performance improvement plan to reduce perioperative hypothermia. Perioperative hypothermia means a patient's temperature drops below 36 degrees Celsius before, during, or after surgery. This project matters because keeping patients warm is not just about comfort, it's also about safety. When patients get too cold, they have more bleeding, infections, slower healing, pain, and longer hospital stays. The main idea of this project is simple. Instead of every staff member warming a little differently, the hospital should use one clear warming process for eligible surgical patients. By the end of this presentation, we will explain the problem, the root cause, the proposed warming workflow, the timeline, and the outcomes we will measure.
First, the problem is that patients can become hypothermic at any part of the perioperative period. The project defines perioperative hypothermia as a core temperature below 36 degrees Celsius. Our project explains several reasons this happens. The operating room is often cold. Anesthesia can make it harder for the body to regulate temperature. Surgical patients may be exposed for the procedure. Also, long surgeries, blood loss, anesthetic agents, and cold fluids can all increase the risk. The reason this is important is that hypothermia can cause real complications. Problems include increased bleeding, infections, poor incision healing, post-operative pain, and longer hospital stays. So the problem is both common and clinically important.
The clinical significance is that this issue affects patient safety and quality outcomes. Perioperative hypothermia is reported in about 80% of patients. It shows that the problem can be very common depending on the setting and the patient group. This project also lists specific risk factors. These include long surgical duration, low operating room temperatures, significant blood loss, anesthetic agents, and the infusion of cold IV fluids. Because of these outcomes affecting both patients and hospitals, preventing hypothermia should be treated as a performance improvement priority.
To understand the cause of the problem, our paper uses an Ishikawa or fishbone diagram. This tool helps organize causes into categories instead of blaming one person. The category in our paper includes people, processes, equipment, environment, patient factors, and measurement. For example, people-related causes include unclear responsibilities and poor communication. Equipment issues include insufficient warmers or the use of cold IV fluids. Environmental issues include cold operating rooms and patient exposure. Patient factors that include old age, lower body weight, and serious illness. But after reviewing all of these causes, the main root cause is the lack of standardized perioperative warming protocol. In other words, the biggest problem is a system process issue.
The most important finding is that perioperative hypothermia is mainly caused by an inconsistent process. Warming blankets, warmed IV fluids, and temperature monitor devices may be available, but they are not always used in the same way for every patient. Without one clear protocol, some patients may not be warmed before surgery. Active warming may start too late, and temperatures may not be checked at the correct times. Staff may also be unsure who is responsible for starting warming and who should keep checking the temperature. A standard protocol would address those gaps by specifying when to assess temperature, who needs warming, when to start the warming, and when to start warm fluids, and how to document every step.
The new warming workflow begins in the preoperative area. The preoperative nurse checks and records the patient temperature. The nurse also screens for risk factors such as old age, low body weight, low starting temperature, or surgery expected to last longer than 1 hour. Eligible patients receive forced air warming for about 30 minutes prior to surgery when possible. In the operating room, the OR nurse and the anesthesia provider confirm during handoff that warming has started. The anesthesia provides monitors and documents temperatures throughout the surgery. They can document the temperature through an esophageal probe, and they continue forced air warming and use warmed IV or irrigation fluids when needed. In the PACU, the nurse checks the temperature immediately. She can either do this orally, under the armpit, or rectally. If the patient is below 36 degrees Celsius, active warming continues and the temperature is rechecked every 15 minutes until it is safe.
Our project changes workflows for several groups, but the changes are practical. Perioperative nurses take the first temperature, screen for risk factors, and start warming when needed. Operating room nurses make sure warming equipment is ready and confirm at handoff that warming has been started. Anesthesia providers will monitor the temperatures during the case, continue active warming, and order warm fluids when appropriate. The PACU nurses check the temperature when the patient arrives, continue warming if the patient is below 36 degrees Celsius, and document how long it takes the patient to return to a safe temperature. Surgeons support the plan by allowing warming devices when they do not interfere with the surgery. Leaders, supply staff, and the quality improvement team provide supplies, training, data tracking, and feedback. These quality improvement measures should be monitored weekly.
The timeline describes a 12-week rollout. During weeks 1 and 2, the team review charts and find the baseline PACU hypothermia rate. During weeks 3 and 4, the team creates the warming protocol, checklist, and staff roles. During weeks 5 and 6, staff education takes place with a goal that at least 90% of staff complete the education. During weeks 7 through 9, the protocol is piloted in one surgical area. During weeks 10 and 11, the team evaluates temperature, documentation, and staff feedback. In weeks 12, the protocol begins in all selected operating rooms. After that, continued monitoring happens monthly, so compliance stays at least 90% or higher.
In slide 9, we'll talk about expected outcomes and key performance indicators. The main expected outcome is fewer patients arriving in PACU with a temperature below 36 degrees Celsius. In the 12-week timeline, the goal is for the hypothermia rate to reach 10% or less by full implementation. The 6-month project goal is to reduce perioperative hypothermia by at least 50%. The process measures are just as important because they show whether staff are following the protocols or not. The goal of at least 95% of patients receiving required temperature checks and at least 90% of at-risk patients receiving active warming. The team will also track documentation, surgical site infections, blood loss, recovery time, and patient satisfaction. These measurements help the team know if the interventions are working and where changes are needed for improvement.
The final part of the plan is sustainability. Our entire project explains that after 6 months and the project ends, the warming process should become part of normal patient care. That means unit leaders continue monthly reviews, give feedback to the staff, train new employees, and ensure supplies are available. The electronic health record, or EHR, can support this by adding checklist reminders for temperature checks and warming methods. If staff miss these steps, the response should be more education and process support rather than just blame. The final takeaway is that the perioperative hypothermia is a patient safety issue and it can be improved through a standard system. One protocol, one checklist, and one team approach can help keep more patients warm, reduce complications, and improve the recovery of all the surgical patients that we see.
To wrap things up, Emily and I learned that keeping patients warm can make surgery safer and have a smoother recovery. With early warnings, regular temperature checks, and a consistent protocol, we can prevent many complications. You could say every surgical patient deserves a little bear hugger, because nobody should leave the operating room feeling left out in the cold.
Bye!